Hello everybody. So this is the GIT chapter which we're going to discuss today, and this is a part of our 90-day university pre-final mastery program. And we're going to rapidly revise all the important topics along with volatile facts which we will be revising very quickly. We'll include all the most asked topics and the high yield topics for the exam. Okay. So these are the few long essay questions and short essay questions which we are going to discuss today. In Auricle, we have recorded classes, live classes, we have practical sessions, we have an exam module and hard copy books. Recorded classes are useful for flexible learning and convenient revision. In live classes, we cover the topics very in-depth way and it also facilitates interactive learning. Express exam module, we have complete syllabus revision in just 20 hours. Covers how to write your exam answers and also it covers how to master exam writing skills. Like you have to incorporate table, how to incorporate flowcharts in your answer. Okay, and it has all previously asked questions which will be discussed in just 20 hours. There's a one-to-one doubt clearing session. There are hard copy book sets and there are question banks with 3 different levels from your Proff exam to your NEET PG level. And practical sessions facilitate hands-on experience and simulate the real-life practical scenarios. These are the subscription plans which you can visit the website and learn more about. So in this class, we're going to discuss gastric carcinoma. We're just going to review it, and then inflammatory bowel disease, which is very frequently asked, GI tract polyps, and also adenocarcinoma of the colon. So we know what is the etiopathogenesis of gastric carcinoma. Okay, what is the etiopathogenesis? H. pylori induced is gastric carcinoma, and there is a genetic predisposition which is nothing but CDH1 gene mutation. Okay, and apart from this, nitrate-rich foods can also result in gastric carcinoma, right? So classification wise, histologically wise, we have intestinal type and diffuse type gastric carcinomas. These are the 2 main types of gastric carcinomas. Okay, so what are the types of gross appearances in gastric carcinomas? We have 4 main types of gross appearance. First, we have an exophytic type gastric carcinoma. There's an exophytic in gross. Okay. Secondly, we have what is known as an infiltrative type. We know there are 4 layers in the intestinal wall, gastric as well as in the intestinal wall. So there is an infiltration. So this is an infiltrative type of gastric carcinoma, right? And then thirdly, we have what is known as, we have exophytic gastric carcinoma, we have infiltrative, right? This is, you can see that this is infiltration. Okay. And then what we have is we have ulcerative type of gastric carcinoma. Ulcerative is a crater-like formation. So we have an ulcerative type of gastric carcinoma. The fourth one is combined type. So these are the gross appearances. Microscopically, we have intestinal type and diffuse type. Diffuse type is associated with, when you see diffuse type gastric carcinoma, it has a leather bottle type of appearance. Leather bottle type of appearance. Diffuse type we know is associated with CDH1 mutation and can also be genetically predisposed. It can also be hereditary gastric carcinoma. So this leather bottle appearance is also called as linitis plastica. Okay, this is also called as a linitis plastica kind of appearance. So which one of these has a bad prognosis, diffuse or intestinal? Diffuse type has a bad prognosis and diffuse type can easily go ahead and metastasize into different tissues. It can cause lymph node metastasis and it can also cause hematogenous metastasis. Okay. So the second thing which we are going to discuss today is inflammatory bowel disease. First of all, inflammatory bowel disease. What is the etiopathogenesis of inflammatory bowel disease? Most of it is because of autoimmune factors. Okay, autoimmune factors, regulatory factors. There are a few environmental triggers and also bacterial triggers which can result in inflammatory bowel disease. So Inflammatory bowel disease, we have Crohn's disease and ulcerative colitis. So, okay. So, among the etiopathogenesis, we need to discuss what are the specific etiopathologic factors. There is a gene called NOD2. Okay, NOD2. And in Crohn's disease, we have polymorphisms in NOD2. We have polymorphisms in the NOD2 gene. Okay, so this is for Crohn's disease. Other than that, there are a few mucosal factors which are helpful in. There are a few mucosal immunity factors which come in for the pathogenesis of inflammatory bowel disease. So, what are these mucosal immunity factors? First of all, we have polymorphisms in genes which code for interleukin 10. From our general pathology, if we remember, interleukin 10, what was the function of interleukin 10? The function of interleukin 10 was to reduce immunity. It was an anti-inflammatory cytokine. There were only two anti-inflammatory cytokines, as we can remember, right? Interleukin 10 was an anti-inflammatory cytokine. And other than that, TGF-beta was an anti-inflammatory cytokine. So these are the two anti-inflammatory cytokines. Now, if there is a polymorphism in interleukin 10, now this anti-inflammatory function is not going to happen. So if this anti-inflammatory function is suppressed, then there is chances that there is autoimmunity and increased immune response instead of suppressing the immune response. So this is one of the mucosal polymorphisms. This is one of the reasons of pathogenesis. Another reason of pathogenesis is autophagy, mechanisms in autophagy. Okay, what is autophagy? Whenever a cell or a protein gets defective, autophagy is a type of cell death mechanism in which there is auto, as the name says, auto is cell. Phagy is similar to phagocytosis. So the cell will autophagocytose and destroy the cell instead of the damaged cell being going into replication. So this is what autophagy is. Okay, the decreased autophagy is another mechanism by which we can get inflammatory bowel diseases like Crohn's disease as well as ulcerative colitis. The third main mechanism which you have to remember is host microbial response. Host and microbial response interaction. What is this host microbial response interaction? We know that there are a few normal bacteria, enteric mycobacteria, which are present in the bowel. Okay, when there is a microbial organism, there is dysregulation of the normal cytokines. We can say that some of the microbes, such as Clostridium, is present. Some of our Enterobacteria, Bifidobacterium is normally present in our bowel. So these bacterium, they produce and T helper cell regulatory proteins. So they produce certain cytokines which help regulate the regulatory T cells. We know there are three types of T cells from our general pathology. There are CD4 T cells, there are CD8 T cells, and there are regulatory T cells. Okay, CD4 are helper T cells, CD8 are cytotoxic T cells. There is a CD4 helper T cell which has a regulatory function also. So these regulatory functions, T cells, are produced by things which regulate these cells are produced by the normal bacteria which are present in the bowel. But if there is a infection from outside, if there is an infection, what is going to happen? It is going to trigger another kind of inflammatory response. So this regulatory function is going to be deranged. Okay, because of that, regulatory function will be deranged, and also something known as dysbiosis will happen. We know when the normal gut bacteria are damaged and it is replaced by other bacteria and the balance is not maintained properly, that is known as dysbiosis. So if this meiosis happens, this is also one of the reasons of pathogenesis of inflammatory bowel disease. So what are the pathogenesis of inflammatory bowel disease? Crohn's disease is associated with, we know, NOD2 gene polymorphisms. We know mucosal immunity plays an important role because mucosal immunity plays an important role in regulation of interleukin 10, which is an anti-inflammatory cytokine. If there is polymorphisms in anti-inflammatory cytokines, then inflammation cannot be curtailed and there will be autoimmunity. Autophagy, also we know autophagy is very essential for regulation of any damaged cells. If that is not there, then also it can result in inflammatory bowel disease. And finally, dysbiosis is a reason for inflammatory bowel disease. So these are some of the few pathogenic factors which you have to remember. Other than that, we have discussed many times about the differences between ulcerative colitis and Crohn's disease. So that can also be asked. Now, we're going to discuss a few polyps of the gastrointestinal tract. What are polyps of the gastrointestinal tract? What is the definition? The definition is growth protruding into the GI tract lumen, and also most important thing, it should consist of some glands and tissue which are actually present in the gastrointestinal tract. There are three main important types of polyps: hyperplastic, adenomatous, and inflammatory polyps. Usually, hyperplastic type polyps and inflammatory type polyps, these are non-neoplastic types of polyps. And adenomatous types of polyps are neoplastic types of polyps. Okay, so we'll see a few of these polyps. We can see here that non-neoplastic polyps are hyperplastic. Okay, hematomatous they've given non-neoplastic, but some polyps which are associated with juvenile polyp syndrome and Fuchs-River syndrome, they can have malignant potential. So they are not completely non-neoplastic. Okay, some polyps which are associated with juvenile polyposis syndrome and Fuchs-River syndrome, they can have malignant potential. Then we have lymphoid polyps and inflammatory polyps. These are non-neoplastic polyps. Okay. What are neoplastic polyps? There are three important types of neoplastic polyps. There is villus adenoma, tubular villus adenoma, and tubular adenoma. So which of these has most malignant potential? Villus adenoma has the most malignant potential, and then tubular villus, and then tubular adenoma. Okay. So these are associated with a few syndromes. I will just review it. We've already discussed them. I'll just quickly review the salient features of these syndromes. We have familial adenomatous polyposis, which was associated with these adenomas. Okay, the salient feature was it had more than 100 polyps, and there was more than 100. There can be any number of polyps. So usually colonic polyps only, and these polyps had 100% chance of transforming into colonic adenocarcinoma, and hence prophylactic colectomy was warranted in these patients. Okay, and then we have Fuchs-River syndrome. Fuchs-River syndrome had hematomatous polyps, as they say here. Hematomatous polyps have extensive smooth muscles in their polyp. I'll show an image now. And Fuchs-River syndrome, the patients, they have mucosal melanosis. Okay, they have blackish pigmentation in the mucous area and the skin, and these patients are very much prone to development of other kinds of cancers, like they can develop endometrial carcinoma, they can develop thyroid carcinoma, they can develop various other types of carcinoma, including this pigmentation. So this pigmentation is a very important clue to identify Fuchs-River syndrome polyp, because this is a hereditary condition, and the hereditary pattern is also autosomal dominant. Similarly, familial adenomatous polyposis also has an autosomal dominant pattern of inheritance. This is a Fuchs-River polyp here. This is a Fuchs-River polyp. You can see these are all some glands which are present, and then this is an extensive smooth muscle. Okay. This is an extensive smooth muscle which is coming in between. So this is a very characteristic of our Fuchs-River polyp. And look at this. This looks like some tree branching, right? So this polyp also has a Christmas tree appearance. This also has a Christmas tree kind of appearance. You can see there is a single stalk over here, and then surrounding this, there is a tree-like appearance. So this is a very classic appearance of a Creutzfeldt's polyp. Which mutation is associated with Creutzfeldt's polyp? STK11 mutation is associated with Creutzfeldt's polyp. It is an autosomal dominant condition. Okay. So yeah, we saw that there are risks of cancer. Adenomatous polyp most commonly causes cancer. Which type of adenomatous polyp? Villus most commonly, more cancer risk, tubulovillus next, and tubular villus. Okay. Okay, so now we are going to discuss the next question with this, which is adenoma carcinoma sequence. Okay, adenoma, usually we know that these adenomas, whichever we discuss, tubular villus, these are going to develop into carcinoma. So there is an adenoma carcinoma sequence properly in colonic carcinoma. Okay, so we're going to discuss this adenocarcinoma sequence. What does this mean? It is a stepwise genetic mutation which get acquired in a tissue. There is a tissue here. There is a first genetic mutation which comes, and the normal colonic tissue will become adenoma. Okay, and then another mutation will come, and this will transform into carcinoma. Okay, so this is the adenoma carcinoma sequence. What is it? It is stepwise approach to stepwise addition of genetic mutation from normal tissue to carcinoma formation. Or there are two pathways of adenocarcinoma sequence. Okay, the first pathway is normal adenoma. It is a conventional pathway. It is known as the conventional pathway. There is an adenoma, there is an advanced adenoma, and then it goes to the colonic carcinoma. And another pathway is known as a serrated pathway. Even in this, you have an adenoma, you have a different type of adenoma. Okay. So first of all, there is a normal mucosa. Normal mucosa is same. Different type of mutation occurs, so different pathway are going to happen. The first mutation, APC mutation. APC mutation, it can occur sporadically also, not necessarily associated with familial adenomatous polyposis, but we know familial adenomatous polyposis patients have APC mutation. Okay, so in normal adenoma also, without familial adenomatous polyposis, there are going to be multiple adenomas, but in normal sporadic cases also, one or two adenoma can occur with APC mutation without familial adenomatous polyposis. That can also happen. So this early adenoma will then acquire a KRAS mutation. Which mutation? This KRAS mutation is the most common mutation in this whole pathway. And then this will develop into an advanced adenoma. Okay. And this advanced adenoma will then acquire a TP53 mutation. Always in the end, you need a very huge mutation. TP53 mutation has to come in. And then you're going to have colonic carcinoma. Okay. This is the conventional pathway. So you can make this flow chart when this question is asked, and also if you can make an image of an adenoma. Okay, I'm just making a very simple image, but you can use your skills and make a nice diagram. Okay, an advanced adenoma, and then a colonic carcinoma. Always when drawing a colonic carcinoma, you have to mention that there is an infiltration over here. Okay, so even though if it's ectophytic, you have to mention there is some kind of infiltration inside the mutation. Okay, then you're going to have BRAF mutation. If you have BRAF mutation, then what you will have is a polyp. Okay, this is a type of a serrated polyp, which is a microvesicular hypoplastic polyp. This can transform into sessile serrated polyps. And then there is one more mutation, CDKN2A mutation, which is occurring. And then this can go ahead and cause microsatellite, two types of cancer, microsatellites unstable and microsatellite stable. So these are microsatellite associated cancers. Now we know that FKP is associated with this conventional pathway. There's one syndrome which is associated with this serrated pathway, and this is HNPCC syndrome. HNPCC syndrome is nothing but hereditary non-polyposis colorectal carcinoma syndrome. And this syndrome has mutations in MMR gene, which is DNA repair genes. And there are 4 genes which are helpful in this context. They are MLH1, MSH2, MSH6 and PMS2. These are the MMR genes. Okay, so mutation in any of these genes can result in HNPCC syndrome. Also remember that this pathway is most commonly involved with left-sided colonic carcinomas, and this pathway is more commonly involved with right-sided colonic carcinomas. Not a hard and fast rule, but mostly. So now we are going to discuss the differences between right side and left side colonic carcinoma. Always remember, right-sided colonic carcinoma are going to be exophytic. They are often asymptomatic and they will present with occult blood in the stool, because slowly they will be there's going to be some blood which is coming out, and since it is in the right side, you will not be seeing frank hemorrhage, okay, because rectum is in the left side, so you're going to see occult blood in the stool. And also you're going to see anemia because there is bleeding happening, and that is why you're having occult blood in the stool. So anemia and occult blood in the stool, characteristic of right-sided colonic carcinomas. Left-sided colonic carcinomas are annular. Annular means now there is a tumor here, and annular is forming a ring around this colon. So when you form a ring around this, what is going to happen? There's going to be constriction and obstruction. So left-sided colonic carcinoma, the symptom will be obstruction. Okay, and also remember MSI tumors, MSI is microsatellite instability, microsatellite stable tumors, right or left. Microsatellite associated tumors are going to be right-sided. FAP associated, APC associated tumors left. Okay. Also, adenoma, tubular adenoma associated tumors are also going to be left. Serrated adenoma left. BRAF associated tumors right. Okay. And RAS associated tumors are going to be left. So this is just a general rule. There can be exceptions also to this rule. Then this MSI associated tumors, the right-sided tumors, they have a mucinous histology mostly. Okay. And they have normal conventional histology, conventional adenocarcinoma histology. They can have a mucinous histology. So that is it. So now we will go ahead and discuss a few multiple choice and case-based questions to just review whatever we have read in this class. A 70-year-old male presents with iron deficiency anemia. Okay, one symptom we have got here, iron deficiency anemia. There is vague discomfort. Colonoscopy identifies large exophytic. So they have given it, there is the cecum. Cecum is the right side. Okay, so this is how the colon looks. There is a cecum. This is the appendix, small intestine, cecum, ascending colon, transverse colon, descending colon, sigmoid colon. Right. So this is the right side. This is the left side of the colon. Cecum is in the right side. Anemia also they have given. So anemia is common in right-sided tumors, as we already discussed. Which of the following clinical or histologic features is most likely associated with this patient's carcinoma compared to left-sided tumors? Okay, so we have discussed most of it. Napkin ring lesion, annular lesion is associated with right or left? It is associated with left. Early presentation of obstructive symptoms. We know that if there is a ring lesion, there is going to be constriction. Constriction is going to cause obstructive symptoms. Okay. So ring lesion, constrictive lesion, going again left. Microsatellite instability, we saw left or right, right. Okay. Higher chance of presented with rectal bleeding, rectum is in the left side, so this is also left. Villus, tubulo-villus histologic pattern, again left. Serrated pattern, right. Okay, so this is, we have solved this MCQ. Next one. A 65-year-old male presents with changes in bowel habits, including constipation and alternating with diarrhea. Okay, a mass is detected in the descending colon and colonoscopy. By biopsy confirms adenocarcinoma. So this is a in the descending colon we have a mass. So they have given in the descending colon. In the descending colon, if we have a mass, this is a left-sided colonic carcinoma. Which of the following characteristic feature is more commonly associated with left-sided colonic carcinoma than right-sided? Mucinous histology, I already said, associated with right side. BRAF mutation we already saw. In the adenoma carcinoma sequence, BRAF mutation was associated with right-sided carcinomas, right? Obstructive symptoms, left side, right side, and deficiency right side. So this is also easily solved. Obstructive symptoms, right-sided colonic carcinoma. Next one. A 50-year-old male is found to have a polyp in the colon that histologically is the tubulo-villus polyp. Compared to tubular adenoma, tubulovillus have which of the following characteristics? Okay, we know the risk. Villus has more risk, tubulovillus, and then tubular. Tubular has the least risk. So among these, what would be the correct answer? Tubulovillus has more risk than tubular. Okay. So compared to tubular adenoma, tubulovillus have which are the following? So it's going to be higher risk of malignant translocation. So this is the answer. Next one. A 35-year-old woman with history of ulcerative colitis undergoes colonoscopy and multiple inflammatory polyps are found. There are multiple inflammatory polyps. We know ulcerative colitis patients, we are going to have lots of pseudopolyps. We already discussed this, right? Pseudopolyps are going to be formed. Pseudo why? Because it's not going to have any gland or any structure of the which is native to the intestinal tissue, but it is just going to be inflammatory infiltrate and fibrin deposition. So that is why pseudopolyp. Which of the following best describes the malignant potential of inflammatory polyps? Okay, we already saw inflammatory polyps and hyperplastic polyps have the least malignant potential. Okay, hematomatous polyps also have very less malignant potential, but when it is associated with syndromes like juvenile polyposis syndrome and Peutz-Jeghers syndrome, it can have malignant potential. Inflammatory polyps and hyperplastic polyps they have very low malignant potential. So this would be minimal to no risk of malignant transformation. Ulcerative colitis as such has a risk of malignant transformation, but inflammatory polyps do not have risk of malignant transformation. That is all. We've discussed most of the questions, and we'll see in the next chapter tomorrow. We'll be discussing more of these frequently asked questions, and we'll be discussing the answers, and we'll be discussing more MCQs on that topic. Thank you.